Hello, I'm Dr. Daniel Frank. This is a video for prospective physicians who are considering a career here at MedNorthwest. This is not a video for patients. If you're a patient watching this video, Washington state law requires you to turn it off immediately. All right, I'm just kidding. But this may or may not be of interest to you if you're a patient, but to my physician colleagues out there, this is just an open message talking about a career at MedNorthwest. Now, when I was an R3 in internal medicine at UCLA, if you'd come to me and said, I've got a great job for you, why don't you just be an R3 for the rest of your life? Well, I would have not wanted to do that. And I see so many of my hospitalist colleagues who seem pretty freaking miserable. I know it's great to have a week on, week off, but did we go through all this just for time off? Doesn't it make more sense to have a career you love? I just don't get it. And then for the docs who are doing ambulatory medicine, family medicine, internal medicine, at one of the big places like Optum or Prov, 20, 25 patients a day blasting through your day like that. I just don't understand why physicians put up with it. Maybe you feel you have no alternative. The concierge model is a way to get away from that. It's a wonderful place to learn and grow as a clinician. I started out in emergency medicine. I trained as an internist. I started out in emergency medicine. I needed, the excitement, intubate people, chest tubes, defibrillate somebody, sew up lacs. But even ER gets old after a while. I don't know if you guys know how it is, but for every one good case that comes in, there's 9 people with a rear end MVA with neck and back pain and no apparent injury. Anyway, here's the thing about concierge medicine at MedNorthwest. We're a strictly evidence-based practice. We use up-to-date New England Journal of Medicine. Nothing here is off the straight and narrow of solid Western evidence-based medicine. So if your practice style is not like that, don't come here or you won't be happy. Another thing about MedNorthwest is the patients here aren't dumb. They're paying extra money and they expect better health care, and we have to deliver it, and we do, and I want them to have that expectation. So here's the trade-off. If you're doing ambulatory medicine right now and you're seeing 22 people a day and you're blasting through your day and you're writing a lot of Z-packs that people don't need, and you're referring every skin rash to derm and every thyroid issue to endocrine, you're not really doing it, in my opinion. You're not really practicing medicine how you were trained to practice. You're doing it out of necessity because of the unbelievable burden of patient care that's dumped on your head. Now here at MedNorthwest, a full day could be 6 or 7 patients. And you might laugh at that, but we book an hour for each patient, but the patient's expectation is a lot higher. This is not about heated towel racks and gold bathroom fixtures. We are wholesalers of concierge medicine, not retailers. I'll give you some examples of what the concierge model is here. Patient comes in, he's got a neck mass. Young guy, maybe he's 40 years old. Well, we've got in-office ultrasound. I ultrasound his neck. I see he's got some big honking nodes up there. I get a neck CT. He's got a tumor, base of his tongue. I send him off to ENT, he gets a biopsy, he has HPV positive head and neck carcinoma. I sent him to an excellent institution here in town, and I'm not gonna say what the institution is other than blank meatballs would be, or a Volvo as a car. I'm just gonna give you a rough idea. And they tell him he should have a big surgery and chemoradiation. Well, then I look at his PET CT and it looks to me like, even though the radiologist called, one side is lit up, it looks like the other side's a little hot too. So I call the radiologist. He says, well, yeah, Dan, maybe you're right. Maybe I should just dictate an addendum. It looks like it maybe is a little hot over there too. And then, of course, I get up to speed on what's the latest for HPV positive head and neck cancer. I review the specialist recommendations and I say to myself, this is wrong. This guy should get primary chemoradiation. So then I send him to the Hutch with a referral letter that says, we're interested in him getting chemoradiation if you agree. And of course, the consult note comes back, yes, we'll get the patient scheduled for chemoradiation. So we saved him a huge neck surgery, big neck dissection that was unnecessary. Now, you guys in the real world could never do that. You'd be like, oh, thank goodness ENT is taking care of this. He's seeing oncology. I'm done. Okay, I'd like to present a few more cases that I think illustrate the type of care that we provide at MedNorthwest. Here's the first case. This is a patient who was panhypopit. And I know what you're thinking. Panhypopit, oh my God, send her off to some endocrine person, preferably at a large tertiary care medical center. And yeah, I mean, that's what we did at first. But what happened over there? The care was a logistical nightmare. Couldn't get medicines refilled, couldn't get appointments, couldn't get questions answered. The patient was incredibly frustrated, and we ended up having to manage her panhypopit. Well, when that responsibility fell to me, I recognized that hormonally this patient was not being managed optimally. And this is nothing against somebody at the U who, even though he may be an outstanding endocrinologist, he's up against an enormous volume of patients he has to see, everything else that's going on that's fighting for his time. And, you know, I have 4 hours to sit there and read up and make sure I'm doing everything perfectly for someone with panhypopit. And the other thing for this patient was she had surgery that was the cause of her panhypopituitarism. This resulted in some injury to her hypothalamus, producing another metabolic disorder that needed a whole other set of medications and approaches. And none of this really was being done up at the U. Here's another example. And, you know, this may be not unfamiliar to you guys, but I had a patient, an older patient, who had a degenerative meniscus tear of his knee, and he had arthritis in there as well. Well, his neighbor was an orthopedic surgeon, so we went to his neighbor, and his neighbor said, "Oh yeah, I'll take you to the OR and I'll fix you up." Well, of course, when I heard that, I practically had a stroke. And immediately I piled on him a whole bunch of articles from the New England Journal of Medicine telling him, look, you know, I can just do sham surgery on you. You'll have just as good an outcome. I mean, if you want to give me $3,000, $4,000, I'll just poke a few holes in your knee with a number 11 blade and we can call it good. And then I did ship him over to Virginia Mason, where the orthopedic surgeons there said, look, you should not have arthroscopic surgery for this problem. When the time comes, you'll need total knee arthroplasty, which of course is the right answer. Here's another case, C-spine fracture in an elderly patient, and this was an older patient of mine with a lot of degenerative changes in his spine who had a slip and fall, and he was hospitalized at Swedish, where the neurosurgeons told him he needed a C1 to T1 fusion. Now, I am not going to criticize the neurosurgeons at Swedish. I'm going to let Google do that, and I'm just going to say that when I saw that this was the recommendation, I was pretty apoplectic. And immediately I said, you know, we're not going to rush and have a C1-T1 fusion. Instead, I'm going to get a second opinion from an orthopedic spine surgeon I really trust. And he looked at the same case and said, well, you know, instead of a C1-T1 fusion, maybe we'll just throw this guy in a soft collar and see how he does. And of course, the net result was he did not end up a quadriplegic. Instead, he had a complete recovery, no pain, and no complications. So I would say these are some additional examples of the kind of care we're providing at MedNorthwest. If you want to be the best, if you feel that in you is a great clinician, that if only given the right environment, that you could be absolutely fantastic, this is a place to come to. If you feel, you know, I'm exhausted, I'm burnt out, I just want to coast and find the easiest job I can, don't come here. It's not really an easy job. It's just a job that's more intellectually demanding. It's more challenging that way. But no, the expectation is you're not going to be here until 9 at night charting. You're not going to blast out of here at 6, have dinner with your family, and then turn the computer back on and be working for 3 more hours. We do control things so that you have a reasonable work day. You can enjoy medicine. You can love medicine again. You can be great at medicine. This is a great environment to grow and learn as a clinician. Now, when I first started here, I'd been doing emergency medicine, and guess what? There aren't too many people walking into an ambulatory medicine practice saying, hey, I think I should probably be intubated. So I had a wonderful opportunity to read and study and really grow my primary care toolkit. You know, it's something that I've been given during my residency training, but then I hadn't used it as much when I was an emergency physician. And I never stopped reading. I never stopped studying. That mindset of continuous learning and continuous improvement, it never left me. So we do in-office ultrasound. We do dermoscopy for skin lesions. We do all sorts of minor surgeries here and joint injections. So if you're interested in this kind of career, reach out to the office, give me a call, come and meet everyone, and we can talk about it if this would be a good next phase for you. We really are looking for great clinicians who want to achieve the highest level of excellence they can as a doctor.